Good afternoon, everyone. And at the outset, it's such a pleasure to be here today. And special thank you to Banshi Sabu sir, Arvind sir, and all the other organizers of Diabetes India. So I'm going to be talking about the novel clusters of type 2 diabetes. And yeah, I have no conflict of interest to declare. So we start by asking the question, are all type 2 diabetes the same? Are all patients the same? Should we treat them all the same way? Well, the answer to that is of course not. How can a person who is young, thin, and has young onset diabetes be the same as someone who has diabetes with age of onset more than 60 years or is obese or has some other problem? So there are so many differences in terms of BMI, response to medications, susceptibility to complications. And truthfully, today, we do not know what drives these various factors. So the first kind of subclustering of type 2 diabetes, which means that you don't treat all of type 2 diabetes exactly the same, started in the West when they started trying to cluster different types of type 2 diabetes. And this is the first data that came from the Scandinavian population by Professor Leif Group. And this is what they did. So they studied about 8,000 individuals, 9,000 individuals. They took all diabetes, not just type 2, but they took all diabetes and took 6 variables to study. So this included GAD antibody, age diagnosis, BMI, A1C, and then they had the HOMA beta, which is a function of insulin secretion, and the HOMA IR, which is a function of insulin resistance. So they took these variables and tried to cluster their population. They then replicated these clusters in some other populations, not very large sample sizes, 1,800, 3,000 individuals, etc. So what did they find? They found 5 clusters of all diabetes, of which the first one called SAID is type 1, and we won't talk about that anymore. But among the type 2, they had 4 clusters. The first was called SID, which was a severe insulin deficient type of diabetes. Then they had something called a SIRD, which is an insulin resistant diabetes, severe insulin resistance. Then they had a MOD, which is obesity related diabetes, and a MARD, which is age related diabetes. So this is what they found. So the question obviously comes, can we apply this clustering exactly as it is to the Asian Indian population? So Asian Indians have a unique susceptibility to type 2 diabetes and cardiovascular disease. And I'm sure people here are very familiar with the concept of the Asian Indian phenotype, in which we have younger age of onset of diabetes. So we have data from the INDIAB study, which shows that age of onset of diabetes starts in the age group of 25 to 34 years. Whereas in any Caucasian population, it's 50 plus. So you see a shift to the left with younger and younger people, thinner people. All of us have seen the thin. It's not just that the young person is very obese and is like the Pima Indian with BMI 35, 40 for them to develop diabetes. All of us have BMI 23, diabetes, 22 diabetes. We have the thin Indians. We still have an increase in serum insulin levels. We have a characteristic dyslipidemia, which all of us almost have, with low HDL cholesterol and high triglycerides and high and small dense NDL. We have increase in inflammatory markers and excess of abdominal and visceral fat. So all of these cause an increased predisposition for not just type 2 diabetes, but premature cardiovascular disease as well. So this is a collaborative study between the Madras Diabetes Research Foundation and the University of Dundee, Scotland, and is funded by NIHR. And the study is called INSPIRED, which stands for India-Scotland Partnership for Precision Medicine in Diabetes. So simply put, this is the clustering which they did in Scandinavia, which is the first part of the table, which you can see here. And this is applying this directly to the Asian Indian population as such, using the same variables, same method, etc. So in the SID population, as would be expected, they are the thinnest people, whereas the obese group is the most obese in this population. right? And you can see A1Cs are highest in the SID group, best in the MARD group, etc. So the HOMA beta is kind of very less in the deficient groups and very high in the SERD groups. So all of these are what we try to replicate. Now you move this exact same thing into the Indian population, what happens? So it starts off with BMI. So the BMI, the lowest BMI was for the SID group, but look at what happened to our BMI. Our obese people were not obese at all, actually. They were quite thin with a BMI of 25, and the SERD had a higher BMI, our MARD had higher BMI. So there were issues right from the beginning. Now, if you look at the HOMA beta, you will see that the least is for MARD, but instead of the insulin resistant group having the highest for us, it went to the MARD. So you can see that this clustering is not sitting very well in our population, or suffice to say, we couldn't replicate the exact same thing in our population. So what did we do? This is a new clustering of our own, and this was published in BMJ Open in 2020. So this is what we did. We took patients from the Dr. Mohan's Diabetes Specialty Center. We had 19,000 individuals with new onset diabetes and duration less than 5 years. For the clustering purposes, we took the following variables, and these are dependent on the Asian Indian phenotype. So we had age at diagnosis, BMI, waist, which is very important considering the visceral adiposity of the Asian Indian. We put in A1C, of course, triglyceride and HDL, which is for our population, and then C-peptide, both fasting and stimulated, as a measure of insulin reserve. So these were the clustering variables, and these were the subgroups that we found. So we were able to replicate the SID group, which is the severe insulin deficient group, and we were able to replicate the MARD group, which is the age related. So these two were similar to what was shown in the West. However, we have two new groups, novel groups, which have been described for the first time in the world, and this is the IROD, which is the insulin resistant and obese diabetes. So for us, the obesity and the insulin resistance are going together. We are not able to separate them out in our population. So we have a deficiency, we have a resistance, and then we have a new thing that's called as combined insulin resistance and deficiency. So this is a combination, it's very unique for our population. Actually, the prevalence is quite low. It's only 12% of all the clustering that we did. But as you will see when you go on, this is a kind of deadly group and is prevalent in our population. So just to take you through how we did the clinical clustering. So when we did our clustering, we found that the age of diagnosis for MARD was 50 plus years. So someone was just asking me, I think yesterday, and saying that 50 years is coming into MARD. It's 65, isn't it, according to WHO? But unfortunately, remember, these are people with diabetes, and we have a shift to left for all our ages. We start early. So even our MARD is at 50, 55 years is the beginning of our MARD. BMI, as you would expect, is lowest in the SID group and is highest in the insulin-resistant obese group. Similarly, for waist circumference, you'll see the glycated hemoglobin is high in the insulin-deficient groups, which is SID, of course, and also the SERD. Now, here start the problems. Now, this is a combination of insulin deficiency and resistance, remember? So here you have a high A1C. You have a high triglyceride and a low HDL, with the best HDL coming for the MARD group. So those are the elderly group. And you have the C-peptide being lowest in the cluster 1, which is SID, and the highest in the IROD. So we now have 4 distinct clusters, which are actually following certain kind of characteristic phenotypes. And that's what we found. Just to show you male-female differences, I'm not going to go through these in details, but just to tell you overall, there was not much difference between males and females. The cluster remained stable. Remember, I said we had new onset diagnosis with duration less than 5 years. So we did sensitivity analysis. What happens to 3 years within onset, 1 year within onset? We tried to kind of do all the reclustering, and the clusters remain stable and replicable. But then the biggest criticism that we had is that this is from a private institute, of course, across the country, but it's still from a single institute. So can this then be applied to the population of India? So we then took the ICMR INDAD study, which is a national database on diabetes and its complications in India. We had 6 of the 8 variables which we used for clustering. So we had age of diagnosis, BMI, waist, HbA1c, triglyceride, and HDL. We had all of these variables, and we reclustered in the INDAD population, and this is what we found. So across India here, age of diagnosis was 55, as I was trying to tell you. If you remember the previous clustering, again, SID had the lowest BMI in waist circumference. The highest was for IROD, as you possibly remember from the previous slide. The glycated hemoglobin was high in SID and SIRD, triglyceride, HDL. So it kind of mirrored the entire clinic population, showing the stability of this across the country. And INDIAB has data from every single state of this country. So even at a national level, the clusters were replicable and stable. And I'd like to say subsequently, we then received data from RSSDI members. So we have the who's who of diabetology who sent us data, and we've reclustered it in their population with their patients. So we have from almost every corner of the country now, and the clusters are completely replicable. And this paper will be going out for publication soon. So what's the clinical relevance of this clustering? So this is the prevalence of microvascular complications across the various subgroups. So look at the prevalence of retinopathy, and this is where the insulin deficient states become important. The prevalence of retinopathy was highest in SID and SIRD. Of course, nephropathy was high in the IROD group, but once you take kidney disease, you'll see that SIRD, this is DKD actually, by EGFR, and you'll see that the SIRD group had the highest. So it has the combined problems of both the resistance and the secretory defect. Now, if you look at the hazards ratios, so again, here you'll see that for SID, the hazards is 1.56. So this is an independent risk for developing retinopathy for people in the SID group after adjusting for various confounders. And similarly, SIRD had an independent risk of retinopathy, which was statistically significant. For nephropathy, we had in SIRD, and again for CKD, we had a very high number for SIRD as well as IROD. So you can see that the SIRD group has risk of complications. Now, what about reaching target A1C? So obviously the green line is the MARD here. So the best, easiest kind of achievement of A1C of less than 7. Whereas if you look at the deficient groups, both the SID and the SIRD, difficulty in reaching an A1C of 7. So this is the first time in India, or rather in South Asia, that clustering has been done, and we were not able to replicate the Scandinavian or Caucasian clusters as is. 2 of them we were able to replicate, but then we have 2 novel subgroups in our population. One is called the IROD, which is an insulin-resistant obese group, and the important one is the SIRD, which is a combined insulin deficiency and resistance. This novel cluster is characterized by difficult to control hyperglycemia and an increased hazards of both retinopathy as well as diabetic kidney disease. So in the clinic, in the GP clinic, OP clinic, when you're sitting in the diabetes clinic, all we need to do is use 6 simple variables which are available in every practice. So your age at diagnosis, your BMI, waist, A1C, triglyceride, and HDL. If you are able to do this, we now have an algorithmic calculator which will kind of tell you where your patient is sitting and whom you need to focus on in terms of early aggressive treatment. And that brings precision medicine to the diabetic clinic in India. Thank you very much.